Okay, we're going to start the panel discussion, and so I'm going to invite everybody, all of our experts, to come have a seat up here. And just again, while they're sitting, I just want to thank everyone again for coming. I was really blown away by the response. I think we filled up about 2 or 3 weeks ago. I've been turning people away over the last several weeks, which I was really overwhelmed by. So I hope everybody enjoyed this. Also, in lieu of an evaluation, I just want to ask everybody to go ahead and email me about anything that you wished to have in the program when we have future programs, or anything that you particularly enjoyed having and would like to see again in the future, or just any feedback you'd like to offer would be really helpful for you to just email the Hopkins TM Center email address. That would be really great. And in the meantime, the way we're going to work this, I'm going to go ahead and I'm going to direct the questions that you have given me towards a particular practitioner, and then if anyone else would like to go ahead and offer any additional information regarding that question, go ahead and go for it. So this first question I'd like to direct to Dr. Pardo. It says, my neurologist told me that TM was a one-shot deal. It hits once, then leaves you alone, but 6 months later I suffered a relapse with more loss of sensation around the rectal sphincter, continues, hold on, and perianal area. What can cause a repeat flare-up, and how often does this happen?
So it's a very good question, and I always mention history. Transient myelitis in the 90s was frequently associated with multiple sclerosis, but we have learned about transient myelitis a lot in the past 12 years. In the 90s, we had no idea about conditions like neuromyelitis optica, or we understood about a very rare condition that was called the VX. But in the past 10 years, we have been learning more and more about neuromyelitis optica that was before in the spectrum of transient myelitis. And that is one of the typical forms of transient myelitis that have tendency to have relapses. So it's frequently associated with an immune disorder in which there is an antibody that is circulating in the body, and once in a while may produce attacks. So that is one of the very well-known myelopathies or transient myelitis form that produce frequent relapses. But the other abnormality, the other disorder that frequently is associated with the recurrence of transient myelitis is multiple sclerosis. And we always tell patients during the first attack of transient myelitis that we need to make sure that we are not dealing with multiple sclerosis, because that is precisely one of the problems in which they have a second attack of myelitis, or even 3 or 4 attacks. But there is a small subset of transient myelitis that occasionally may have relapse. So we always say in the papers that approximately 90% of the patients with transient myelitis will stay as transient myelitis. But in the past several years, we learned that probably between 20 and 25% of patients that present with transient myelitis may turn to be multiple sclerosis. And so that's the reason many times during the initial assessment of multiple sclerosis, of transient myelitis, we need to do a lot of testing to rule out the possibility that the patient may have multiple sclerosis. Just to summarize, in the particular situation of this question is every time that there is relapse after the first attack of transient myelitis, we need to make sure that we check if the patient has neuromyelitis optica. Because if there is neuromyelitis optica, Dr. Levy already outlined that it's one of the transient myelitis that we are able to treat easily because we already know what the problem is. So we can either do plasma exchange or do immunotherapy or use any of the medications that Dr. Levy is using. Or if there is a second or third attack, and later we find out that there is multiple sclerosis, we need to treat that problem specifically as
I also want to mention, we did a study. We looked back at our last 10 years of patients who came in with their first TM. We asked the question, what is the chance that they're going to have a second attack? What factors could predict that? And there were really three that came out of it. The strongest was race, actually. So African Americans were much more likely to recur than Caucasians. We didn't have enough data from Asians and Hispanics, but it looks like Caucasians are sort of the most likely to remain monophasic, one attack, and the non-Caucasians are more predisposed to have more attacks. The second was female sex. So females were almost twice as likely as males to have a second attack. And the third was age. The older you are when you have your first attack, the more likely you are to have recurrence. It doesn't mean that just because you're 40 when you have your first attack, or you're female or you're African American, it means you're going to have a second attack. But it just kind of gives us a clue that maybe there's something to either follow closely or about.
Why don't you hold on to that? Dr. Levy, are you using your own patient's stem cells or a lab-generated stem cell?
Yeah, the lab-generated stem cells are the ones we're using right now with the FDA. To get a product approved takes a long time, takes a lot of toxicity studies and many years of work, which we started to do here at Hopkins and have had variable successes, but there are already several companies out there that have been able to get approved lines. These came from other places, either fetus or adult or someone else out there that we now have been able to manipulate for use in transverse myelitis. And so those are the ones we're using for the trials.
Okay, I'd like to direct a question to Dr. Newsome. People have said on the panel that TM is defined as having one lesion. Is it still TM if you have another lesion a year later after the first lesion occurred?
Yeah, that's an excellent question. That goes back to the original question about recurrent TM. And so if you're having another lesion form, especially if there's a clinical correlate to it, then it takes it out of that one-time monophasic event of TM and puts it into the sort of umbrella recurrent TM. Now, there are a lot of causes of recurrent transverse myelitis, and Dr. Pardo had nicely mentioned a couple of them. So at least in, I think, the majority of our practices, if we see someone that presents with one monophasic TM, quote-unquote, we're going to follow those patients very closely for the first at least 5 years. Because it really seems, in the 5-year rule, I'm not quite sure if we stole this from sort of like the cancer things, but it seems like 5 years, if 5 years go by, if the person has not had another clinical attack or new lesion form on imaging, then the chance of them going on to have another attack later on, or new lesion form, is extremely low. It's not zero, but it gives us a little bit of comfort to say, okay, maybe instead of doing MRIs every 6 months, let's do it every year, maybe every other year. So for 2 lesions separated in time, that takes it out of the one time. You have to start looking down the road. Is this MS? Is this optica? Is this sarcoidosis? Is this some physiological conditions? And so the list sort of goes on.
Dr. Kaplin.
Yes.
Are there any ongoing or upcoming trials to deal with the mental damage caused by TM?
So that's a great question. 2 things I just want to mention is, one, I just think we all ought to have a round of applause for Green, put this whole thing together at no extra pay for staying up late and putting this together. So can we all just... and making us look good. So that's hard to do. So, so as far as upcoming trials, this also brings up another issue. So we have, right now, we are looking for funding in order to do additional trials. We have ongoing trials that are looking at existing medications, but what we really want to do for the cognitive impairment, for example, is be able to take some of the work that we've done in mice imaging in humans, patients with transverse myelitis who permitted us to do the imaging of multiple sclerosis, and allowed us to develop this pathway and these drugs that have never been tried in humans. We are trying to move this on to the clinic. It turns out that, and this is just what I want you guys to know, the reality. You guys have all probably heard sequestration and the effects. So this basically means that NIH funding was already at about 10%, which means you have to get an A or an A plus in order to get anything. So anything but an A or A plus has failed, which means 9 out of 10 of our ideas doesn't get funded through the NIH. So you've heard about, some amazing trials that are ongoing. I was very impressed hearing Dr. Levy talk about a number of the trials, and that's being funded through pharmaceutical or, stem cell companies for some of these. The other thing, though, that I want to mention is that there is one thing that really makes a big difference, and you'd be surprised at how important this is that we now are in the position that if we just get some pilot funding, we can then apply to the NIH and show that there's sort of proof in the concept of some of the ideas. So, for instance, Melinda Smith here was able to do a golf tournament, which I know isn't easy, but if you can find creative ways of raising funds, that has allowed us to go on and begin to test some of the ideas about the scuba in the laboratory. So just believe it or not, a few $1,000s can actually make the difference in being able to pilot some of these studies. So the long answer, I just gave you the short answer is yes, we are trying to get funding for additional studies. We do have plans in place to begin some of the studies, but right now we don't have a study that I can tell you recruiting people for currently. So long answer, but hope that covers it.
All right. Dr. Zackowski? Would there be more than one lesion if both hand and legs are involved in paralysis?
Good question. So where the location lesion is that you see on the MRI sometimes relates to the kind of dysfunction you have, and sometimes it doesn't completely relate. So that's part of the issue, that the MRI might not be picking up all of the detail, but you know that your symptoms are that your hand and your leg are impaired. So it's possible that there are multiple lesions that cause hand versus leg dysfunction, but it's also possible that one lesion in your spinal cord could cause both your arm and your leg to be impaired. And that's because if you think about it, all of the neurons from your brain get literally funneled down to this little spinal cord that's about the size of your thumb in diameter. All of them go through there, so you can imagine that a little lesion in the right place could affect neurons that go to my hand or go to my leg, because everything gets squished into this little space.
Dr. Becker, I have a question for you, and I just lost it. I'll make it up. And you may want to weigh in also. Are you presently using stem cells to generate the affected TM area, and then physical therapy is prescribed?
So we don't have an active stem cell trial for us.
Okay.
We have done interesting data like that in the laboratory a couple of years back. Because I didn't give it my whole story, but before I did the whole neurology part, I was very heavily involved with stem cells in spinal cord. And we later on came onto the adding activity as an independent way of helping repair the spinal cord. And we presented a paper a couple of years back where we combined the two. We combined a stem cell transplantation with functional electrostimulation. And we're able to show that if activated with electrostimulation, stem cells survive better and they differentiate better. So my take-home message from that was that if or as stem cell trials come down the pike, I think it's still going to be very important to combine these new therapies with activity to help maximize the repair that we get from cells.
Dr. Mayer? If you have paroxysmal motor spasms near the heart, say at T4 area, can it damage the heart if the spasms are frequent?
So spasms are affect what we call skeletal muscles, or muscles that move the limbs or the trunk. They don't affect internal organs. So fortunately, the answer would probably be no. The only way it affects the heart and lungs is kind of indirectly. If you get prolonged spasms over a long period of time, you can get a curvature of your spine, and you could get some pressure on the heart and lungs that can indirectly cause some problems if you're a high-level quadriplegic patient, for example. Some issues with that, but not directly from the spasms.
Dr. Newsome.
Taking a tally, but how many answers?
Are you winning?
I think so.
Okay. Somebody's neurologist showed them their MRI with one big ball-like lesion in the spinal cord and 2 lesions in the brain. The doctor refused to diagnose MS based on that and said it's TM until they have a second attack. Is that correct?
So give me the hard questions.
All the discussion today about TM was
yes.
about a single lesion in the spinal cord.
How many lawyers are there?
Right. So no, that's an excellent question, and we see this in practice. Sometimes up front it's not clear, again, whether the transverse myelitis attack that someone experiences is going to be sort of a thing. What we do know from studies that have been validated over time, multiple sclerosis, that if you have multiple lesions disseminating in space, meaning multiple areas of the nervous system are involved, then there is a high likelihood that the first clinical event that someone has, you have a higher likelihood of going on to have another attack, clinical attack. Now, with respect to multiple sclerosis, they're always revising these criteria. How many lesions when do you need to have attacks? And so actually the most revised version of it's called the Pardo criteria says that you can actually make a diagnosis of MS with one attack and one MRI. And that goes back to sort of if you have the right number of lesions, even if the lesion is not causing the symptom, and you ruled out sort of all the mimickers of MS, esophagus, sarcoid, lupus, etc., then you can be more confident to say, okay, there's a high probability that this was not a one-time attack, and that now actually a lot of us are starting people on medications even in that scenario. So 2 lesions, though, I always tell people that it all depends on real estate again, where are lesions located, how large are they. A lot of us, if you just do a brain MRI who don't have neurological conditions, will have these spots in our that doesn't mean MS or esoptica. That can happen with aging, smoking, diabetes, hypertension, cholesterol problems. So not every white spot in the brain means that you have a neurological issue.
Okay.
I think that answered.
Yep. Janet, this is about the success rate with ACE procedure and complications involving that. If ACE procedure is unsuccessful and it's permanent, what happens to the bowel regimen?
So the ACE procedure, and there is more literature in kids with spina bifida, which is a lower motor neuron lesion. I'm not sure about data in adults. The procedure isn't done as often, I don't think, in adult populations as with children. But with children with spina bifida, the ACE procedure has been. Now, the ACE procedure is for bowel, and that is not as complicated a procedure as the one that they do for black. So I don't think it would really cause much problem if it wasn't successful. You go back to doing the other bowel regimen. But I'm not aware of specific data. The complications are low with the procedure. The problem, though, sometimes is that when you use an enema, a large volume enema from above, people tend to have like leak for longer periods of time after they've done a bowel program than they would if they're just using suppository. So for some people, it just does not, it just doesn't work as well.
And then follow up to that, ACE and
Cecostomy.
Yep.
So they're both the same procedure, except the cecostomy, it's, if you look it up online, it looks like a little pigtail that goes from the skin. It sort of, the interventional radiologists put them in and you lightly sleep, and then it's literally kind of screwed in. It's pushed in and then screwed in. It's a flexible plastic, and it's got a little port on it that you open and close that goes between the skin and part of bowel. And so it's completely reversible if it's not successful. When I've talked to the doctors that take care of children with spina bifida, they often advocate the ACE procedure because you have a permanent tract, where the cecostomy there is some danger that it can move and get dislodged. But to my way of thinking, I'd rather try something temporary to see if it would be useful that can be removed. And it's also something that is often put in just under kind of a local anesthesia. That doesn't involve going to the operating.
I can't quite make out everything, but is there, whether somebody had a flaccid versus a spastic condition, would you?
It's used mostly with people with flaccid. With flaccid.
Dr. Levy, since in mice it was seen that stem cells migrated to where they were needed, will it be expected that this will happen in humans too? So that one day invasive surgery will not be needed, i.e., will stem cells be able to be injected someplace else in the body, like peripherally, and have them migrate to the spinal cord?
Yeah, that's a really good question, especially since I was on a patent in 2010 for genetically engineered stem cells that could be injected into the bloodstream that could then be directed to go directly to the lesion. It's not a new idea anymore. There are a lot of companies that are looking to do it this way for places like joints, for stem cells, stem cell repair of joints, central nervous system diseases, pancreas, things like that, where you don't want to necessarily have to open the body or use a very invasive procedure to get the stem cells to there. And for patients with MS, for example, that have a lot of lesions, an approach using something like an injection into a blood vessel would be a lot less invasive and easier. So that's something that's being developed. It's not in any sort of trial yet. Just because it works in a mouse and it worked really well in a rat, if you go to my lab and look on the wall outside of my lab, I have pictures of how these stem cells stuck in the rat brain. It works really well, but I can't guarantee that it'll work that well. We hope, sir.
Dr. Kaplin?
Am I speaking for the rats?
No comment. Has Prozac been found to be the most effective SSRI in depression, TM depression, or what others are useful?
So it's a good question. What I can tell you is that Prozac has been around for since 1988, and because it's been around so long, it's been available off patent for use in a lot of research programs. So what's interesting about Prozac is that we know the study that I showed in multiple sclerosis patients who weren't depressed in a double-blind study, it showed that there were significantly fewer lesions in patients with MS. Be nice again, although that was the best kind of study we have, double-blind control, it'd be nice to see anything replicate. But also since then, Prozac has also been used in the FLAME study, which showed that people who had strokes and have weakness on one side of the body or the other have better recoveries if they are using Prozac again in the FLAME study. So it's been around longer that more studies have been done on Prozac. Having said that, there's no reason to believe that there's anything really special about Prozac in terms of its effect on serotonin. So Prozac is a SSRI, serotonin selective reuptake inhibitor, and all of the other SSRIs work through the same mechanism. They may have additional things that they do, but they all tend to increase serotonin levels. So there are no reasons to think that the other drugs shouldn't work equally as effectively. What we tend to do when we're prescribing medications is match the symptoms, the side effects, or the indications for the medications with the individual, or try to use something that has the fewest drug-drug interactions to not interact with anything else. So Lexapro, Zoloft, very few drug-drug interactions, and then this is something you should talk to someone skilled in the use of these medicines. Prozac effects tend to be energizing. Paxil tends to be sedating. Tricyclics, I was just talking to someone earlier at the break. Tricyclics have, as Dr. Newsome mentioned, that you could, if you happen to have trouble with bladder, migraine headaches, or neuropathic pain and depression, tricyclics happen to affect all of those. So you could have one drug do multiple things and sort of streamline. Cymbalta also has indications for pain. So what you really want to do is, I could tell you that there are lots of variables here. That's why we go to school and learn about this stuff. You really want to talk to someone skilled in the use of these medicines, because there's no reason to think that any one of these drugs is going to be necessarily better than the other. As well, each individual. That's, unfortunately, we don't have a blood test to predict yet who's going to respond best. It's about a 60% response rate for any of the medicines, and you have to just try them, find out.
Dr. Becker, I'm going to pick on you. Please address reproductive issues in TM.
How did I end up with that question? Do we have a more specific question? So, because sexual function is very much affected by transverse markers, like in males and in females. So, there's no fertility issue in women, so that's not a problem.
I think it's more, is there any reason that you would need to worry about having to become pregnant in TM?
No, actually, we have many women we follow in our center who have had some very successful marriages, very successful pregnancies, with beautiful babies. So there's really nothing we have to be too concerned about. Yeah. So Dr. Mayer just points out, so there is, so if you have lesions at level T6 or above, there is the risk of having autonomic dysreflexia, which probably can be accentuated by pregnancy, at least by delivery. But I don't have enough people to, I have not seen it, I must say. Oh, that's right. So you have to always be careful, when you're pregnant, the drugs that we're using for nerve pain, spasticity, to make sure that they are actually still taken when you're pregnant. Actually, Dr. Zackowski probably has the most experience with pregnant people. But very experienced.
Just want to add to that real quick. So you bring up a great point. I think we have to be mindful of what type of disease process the person may have that caused the transverse myelitis. And, we always have to go back to the drawing board and say, well, if you're on a particular medicine that is preventing further attacks, further relapses, further spinal cord attacks, is it worth risking to come off of those medicines for a while to get pregnant? And so I can tell you I'm not going to put hands up or ask people to put hands up, but depending on the disease, we have a lot of patients that say, you can come off your therapy, wash out of that therapy for a period of time. Usually, at least in MS, it's a few months for most of the drugs. And then once pregnancy ensues, at least for MS, doesn't speak to things like lupus or NMO, but there is a relative protective time in pregnancy. So we'll educate patients about that, tell them, especially the second, third trimester of the MS, it seems like estrogen goes up and it's a relative time, which is important to note because people fear of having an attack while they're pregnant certainly happen. But you really have to look at what disease process is present that caused the TM. It's a monophasic episode of TM, certain that it really wasn't idiopathic TM, and don't necessarily have to worry so much about the medications outside of the symptomatic ones.
Dr. Pardo, what viruses are known to cause TM?
It's a very good question because many years ago, every time a patient had myelitis, viruses were the first suspect. And we still have viruses as a first suspect in myelitis, particularly viruses that are in the family of herpes viruses. Herpes virus has several different types of viruses that may produce myelitis, particularly when patients are in a stressful situation, some type of immunological dysfunction. So all of us have viruses in our body. All of us have viruses associated with herpes infection. But occasionally our immune system goes down and allow viruses like the virus of varicella zoster or chickenpox, and that virus may attack spinal cord. We are paying attention to viruses when a patient has transmyelitis because we have medications that can be for those viruses. Unfortunately, there are some new viruses in which we don't have good tools to treat the virus. For example, the most common one in the last few years is West Nile virus. West Nile virus is becoming a problem, and last year there was a huge epidemic of West Nile virus in Texas. And occasionally that virus may produce inflammation in the spinal cord. So the summary is every time that a patient comes to the emergency with concerns about acute myelitis, we always check for a virus that we recognize as myelitis. But at this moment, fortunately, viruses is not the main issue. I think that we need to pay more attention to immunological disorders, sclerosis, and even other potential causes of like vascular.
Dr. Mayer, after the initial TM event and then kind of more chronically over the years, how long can symptoms develop and then continue to last in terms of months and years?
Well, that of course depends on the symptom, but if they're referring to spasticity typically develops within a few months of the initial lesion. There may be a period of time some patients are actually initially flaccid and then develop spasticity later. We more commonly see that with a traumatic injury, inflammatory. But you can get symptoms later. Sometimes spasticity is progressive. It's not commonly progressive. Usually it's about the same for time and treat it. Hopefully get it a little better, but we don't also barely get it completely better, so that most patients who have spasticity wind up on medication for life at this point. Of course, we hope with things like stem cells that we won't have an issue. I think with activity-based therapy, we can control it to a large degree and sometimes get people off medicine, so that's very hopeful that simple things like exercise or electrical stimulation do help. And then, of course, if you get things like an infection or an irritant, those are things that can worsen spasticity, at least temporarily. So,
Dr. Becker, could you address that question from the acute phase of TM? How quickly symptoms can come on and last in the acute phase?
Also, and that's the way you know that you have spasticity, because you have symptoms. Usually the most sensitive thing that tends to happen first is like loss of bowel, bladder, and sexual function, and then people difficulty with sensation, weakness kicks in, and these things can happen within, in extreme cases, within minutes from the time the things start, and then it becomes always very important for us as experts in endostomatitis to figure out how long does it take from the first symptom to your peak, or what we call nadir in ADIR, which sort of helps us to sort of differentiate what was your transverse myelitis caused by. So we have some people that go from onset of symptoms to maximum within like 15 to 30 minutes. And then we have other people where it might take 7, 10, 14 days to actually get to maximum. But once you reach nadir, then generally things start, in the majority of cases, start getting better.
So I'm going to respond from a therapist's perspective. I agree with Dr. Mayer that there's activity, stretching, exercise can often address some of the spasticity, but what I want to make sure everyone's clear on, it's not just general activity that's going to perhaps change spasticity. I think there are certain stretches that you want to do that will affect the muscles that are giving you the trouble, or you want to monitor this a little bit more carefully to get the best effect. So if you have spasticity, I think go to a physical therapist, a neurologic physical therapist who understands, at least may not have a lot of experience per se in TM, but might have experience with spinal cord injury, and ask them to really address some of the more activities kinds of approaches that you can have. Because it's not just as simple as just exercise or just stretch generally. I think there are specifics that are important to.
Dr. Newsome? You answered other people's questions too. That's not my fault. What is Crohn's disease effect or relationship with TM?
Yeah, that's an excellent question. So Crohn's disease, as many of you know, is a disorder of the bowels. It's an inflammatory bowel condition that at this point is, we think, autoimmune in nature. And so how it relates to transverse myelitis is that if you have one autoimmune condition, you're more susceptible to have another autoimmune condition. And that's not 100% across the board, but the analogy is, thyroid disease is very common in just general population. But we do see thyroid disease at a higher prevalence in multiple sclerosis and some other conditions. So it just gives us an idea that there's an autoimmune dysregulation that's happening in someone's body, and whether it's the bowels that are getting attacked, the joints, or the spine, it all depends on the disease process. But as far as a direct link from like a genetic point of view, to my knowledge, I don't want maybe some.
Inflammatory disorders of the bowel are very interesting for neurology and for any other neurological problem, particularly because our bowel is populated by millions of bacteria. So when patients have inflammatory bowel disease, there is a risk of some of those bacteria or bacteria products to go to the bloodstream. It's a phenomenology that is called microbial translocation. So patients with inflammatory bowel disorder are at high risk of experiencing high states of a neurological activity, and that is going to influence all the system in the body. And if a patient has any neurological disorder like transverse myelitis, multiple sclerosis, even a stroke or any other neurological disorder, those patients are going to be in a higher risk of experiencing more neurological symptomatology. That doesn't mean that the baseline disorder, the brain or the spinal cord, is going to be exacerbated. That means the systemic inflammatory reaction that happened because the bowel inflammation is affecting secondarily the brain and spinal.
Janet, what is the impact of Imodium on bowel movements in patients with TM?
So Imodium is generally a medicine that's used to slow down transit of stool. I don't use it very frequently. I don't generally have problems with patients that have diarrhea as much. And if I have a patient that's having diarrhea, I'm suspicious that they're having constipation, impaction, with then stool leaking from above. And in that case, I wouldn't want to use Imodium. I would want to use something to clear out all that stool that's backed up. And the way sometimes you can decide if that is actually the case is to just get an x-ray of your abdomen, and you can see which stool is back in your abdomen. So that's my thought.
Can I have a follow-up with that Crohn's thing?
Sure.
My wife has both. And the initial attack of TM was back in 2010 or I forget now. And during that span of time between the first one and the second one, because of the Crohn's disease, she was put on something called the Prezo. After with the second one, episode of TM, in visiting the neurologist, she noticed in the contradiction part of the thing, it said that Prezo may be a cause of TM. That was one of the ones listed on, actually at the very bottom in the smallest print possible. Can you comment on that at all?
I'm not familiar with that as a potential cause of transfer myelitis, but when we have the overlap immunological problems, overlap immunological syndrome that Dr. Newsome mentioned, the main goal of the treatment is to treat the immune system and make sure that we shut down the immune system to avoid that the overactivity of the immune system produces a lot of problems in the spinal cord and also the bowel. So I'm not familiar with the description that you are.
Yeah, just say a couple of words. So with clinical trials that are involved with various medications, if one or two people have a severe adverse event, it has to be put sort of somewhere in the packaging insert, especially if it happens more than once. Now, does that mean that it's totally related to the medication that someone received, or is it sort of unrelated? It's a perfect storm situation, meaning that someone may be predisposed to have one autoimmune condition, maybe, for at least MS, vitamin D deficiency seems to play a role. Maybe there was a viral infection. And all this together is what provoked the TM. So it's not real clear. As far as the medications that we use, I mean, there are some medicines. I'll just tell you a quick story. There's a medication that we use to treat a patient who had transverse myelitis, which came to find out is the neuromyelitis optica variant. Treated medication that shifted the immune system in a way that actually brought out lupus. Now, you could imagine, well, we know that some of the rheumatological conditions can coexist with NMO, but we wondered after the fact that did we tweak the immune system to a degree that it shifted its immune profile to activate another autoimmune condition. So theoretically, it can happen. So I'm not sure if that happened in your situation.
You remind me, there is sort of rheumatological disorders that are treated with medications that are called anti-TNF alpha medications that are very good for skin disorder like psoriasis or Crohn's disease or other type of immunological disorders that may trigger immunological disorders in the spinal cord or in the brain that may make multiple sclerosis or even transient myelitis. So again, we need to be aware about the risk versus benefit when we use all of these medications. And occasionally, we cross with very particular situation in which we are giving one medication to a patient for one specific problem, and unfortunately, because the medication, patient may develop other type of complications.
Dr. Levy. How will we know when the stem cell clinical trial is, and will insurance cover it?
Insurance probably won't cover the trial, but if you participate in the trial, all expenses will be covered. Once the trial is complete, if the stem cells prove beneficial, maybe insurance companies will cover it. The benefit would be that you hopefully will treat the underlying problem and can reduce a lot of the disability and cost associated with that. So maybe insurance companies' best effort. Now, if you really want to know when the trial will take place, keep tuned to myelitis.org and to our transverse myelitis website. Call Maureen every day if you like, every morning, 9 a.m. when she gets in, and ask her if the trial is going on yet.
So I will take the opportunity to make a political statement. The trial that is going to be done at the National Institute of Health is going to be done at the National Institute of Health. That is your tax money. And scientists depends of NIH a lot. And at this moment, we are in trouble because the funding for NIH is going down, and it went down in the past 5 years. And unfortunately, with the latest events in Washington, it's going to keep going down. So when you are paying your taxes, you are paying for the treatment and you are paying for the research that we are doing. So my comment is just keep the pressure on your congressmen, senators, and say, we need to support NIH, we need to support research in this country, because otherwise we are not going anywhere in the treatment of all of these disorders.
I'm going to open this question up to the panel for whomever has anything to add. Does diet impact TM by increasing or decreasing symptoms?
I'll speak on that just a second. So I think there's a lot that we don't understand about diets, and going back to sort of the drawing board, if you have certain insensitivities to different foods, gluten comes to mind. So if someone has gluten sensitivity or celiac disease, we know that that can cause neurological problems. And in the right situation, if someone is predisposed to transverse myelitis or some other autoimmune condition, you could imagine a scenario that, and it's this perfect storm situation that happens. If you constantly expose the body to an allergy, in a sense, that's going to activate the system to a degree that then spill over to whether it's transverse myelitis or something else. And I think it's challenging. There have been a lot of diets. I'll speak to MS because I think this is probably the one disease that's been studied most with respect to diets. There has not been a specific diet proven to work in it as far as cutting back these attacks that individuals can have or MRI activity. However, that being said, there have been some recent studies showing that the Mediterranean diet may impact the immune system in a way that some of the other ones do not. Mediterranean fish, vegetables, fruits, etc. And intrinsic into the Mediterranean diet, I think it's probably a lot of vitamin D, fatty acids, the good fatty acids that are. So there's probably some relationship there. Wine. If you're men, we're lucky we get 2 glasses of wine. If you're females, only 1. So there's a lot that we don't know about the diet, though. And I think going back to Dr. Pardo's point about the bowel, there may be a lot that's hidden within the bowel that we just don't understand. So there may be some foods that adversely affect the bowels that can activate or deactivate the immune system. So we'll have to see. There's more to come.
Anyone else? Okay. I actually have a comment from an audience member with TM. She wanted me to relay this to the audience. I lived in braces bilaterally for 12 years and was told nothing could be done for a drop foot. When I met with Dr. Mark Meyerson of Mercy Hospital in Baltimore in April 2011, he reconstructed my left foot and did a tendon transfer on the right. I now walk brace-free, which has improved my gait and morale. Joyce Heritage. So she wanted me to share that with you. So again, I want to thank everybody for coming. we're all done. If you have any more questions, please feel free to just come up individually. We're going to be lingering around just for a few more minutes, but
Do you still use cell set for somebody that has reoccurring?
yes.
Yes.
Use CellCep for recurrent transverse myelitis. No.
So,
Us.
the Myelitis Association, they provide you that information. The Myelitis Association has a website. You can communicate with them.
Thank you, guys. Thank you, everyone, so much.
Thank you.
Thank you. I was only kidding about that. You know I was.